Good morning and Happy New Year. The Insurance Committee of the Tennessee House of Representatives of the 114th General Assembly, year 2026, is now in session. The time is few minutes after 10:30, and today is January 20th, 2026. To start off this year of the meeting, I'm sure we have agendas and we have thoughts in our head. To clarify those thoughts and put them on a better footing, I've asked Chairman Hale to open us with a prayer.
Let us pray. Our most kind and gracious and loving Heavenly Father, Lord, we gather today to not just as a certain party, but God, we come together today as a committee, as Tennesseans, Lord, to carry on the business of the greatest state in this country. And Father, we just pray that you would guide our thoughts. We pray that you would be with us, not just today, but each and every day as we have conversation, as we have debate, and as we pass legislation, that we would have at the heart of everything we do what's best for Tennesseans. God, I pray that you would be with us, that we would be your example, that you would lead us and guide us. Lord, your word says that the steps of a good man are ordered by you. So, Lord, I pray you would order our steps today and each and every day. Forgive us where we fail you. In Jesus' name, amen.
Well, thank you. Thank you. That's a great way to start our year. Members, it's time for us to reintroduce ourselves, and I'm sure most of you remember Yes, I'm sure most of you remember your codes that you put in. Otherwise, our chief clerk is around to help you. So let's log in, because that is what records your presence and your role in the committee. I think most people have already accomplished that. So we'll start with introductions. We can start on the right side. Chairman Grills.
Good morning. I'm Rusty Grills. I live in New Bern, Tennessee, as far west as you can go and still be in Tennessee along the Mississippi River. I serve Dyer, Lake, and Obion counties, District 77. I have a wife of 20 years this coming March and two daughters, Hadley and Jaxie. Hadley's 15 and Jaxie's 12. Thank you, Chairman.
Thank you.
Thank you. My name is William Slater, and I'm honored to serve the 35th District, which is the southeastern part of Sumner County and then all of Trousdale County. Blessed to be married for 45 years. It'll be 46 this year, 4 kids and 7 grandkids.
Hello, I'm Kevin Raper. I'm from Cleveland, Tennessee, serving District 24, and I am married to a lady of 33 years and still growing, hopefully. And the last thing is this, I'm a big Vol fan, and my son's names are Nealon and Manning. Yes.
All right. My name is Rick Scarborough. District 33 makes up Anderson County, Oak Ridge, Clinton, Norris, and Rocky Top. Enjoyed serving last year too, Dr. Kumar. Married, got a house full of grandkids now too, and again, just happy to be here. Thanks, sir.
Well, thank you. I'm chairman of this wonderful committee. I'm Sabi Dak Kumar. I've served since 2015 in this House of Representatives. I represent District 66, which is Robertson County, immediately north of Davidson County. And our motto is that we are minutes from Nashville, miles from ordinary. Lon, go ahead, please. Yeah, we'll let our staff and attorneys also join in the introductions. Oh, we forgot you.
My name is Levin Crutchfield, and I serve as the staff attorney for the House Insurance Committee.
We forgot Ryan.
Hi, I'm Ryan Vallone. I'm the House Research for the Insurance Committee.
And Carly.
I'm Kylene. I work in Chairman Kumar's office. So if anyone has any insurance-related issues or concerns, make sure you let us know.
Okay, Joe.
Thank you. I'm Representative Brian Terry. I represent District 48. That's the eastern half of Rutherford County. I have the MTSU. I have the monument for the absolute center of the state of Tennessee in my district. and we will be home to the new Buc-ee's soon. I have a wife of Cheryl of 34 years, 2 children, Braden and Breeley.
Hi, I'm Esther Haynes. I represent House District 30, which is part of Hamilton County. I live in East Brainerd now in Hamilton County, and I am married. I have 3 children, 5 grandchildren, and it's great to be back.
Michael Hale, District 40, Cannon, DeKalb, Smith, Jackson, and a part of Wilson County. Great honor to serve in my second term. Beautiful wife of 30 years and 3 children, 5 grandchildren. 2 of them were added this last year. So I love spending time in the rocking chair with them. So, and then on the side, my real job, of course, is owning a funeral home and then farming, and then still do some preaching and fill in pulpit supply. So very blessed man. Thank you.
Good morning. I feel like a slacker compared to you. My goodness. Okay. I'm Deborah Moody. I represent District 81, and that's all of Tipton, a part of beautiful Haywood County in West Tennessee. And we too are on the Mississippi River, just a little south of Rusty. And I am married. We'll have our 47th anniversary this year. And we dated for 5 years. So go ahead and do that math. But anyway, we are happy and have children and grandchildren now, and just living the dream. Thank you.
Chairman Spark. Yeah.
My name is Donnie Williams. I'm a former state trooper. I will be here as y'all Sergeant at Arms.
Mike Sparks, District 49, Smyrna, Laverne, a little bit of Murfreesboro. Married to my beautiful wife, Felicia. She was 15. I was 19 when we started dating. And got 2 sons, Preston and Peyton, 2 grandbabies, Grace and Henry David. And I'm just glad to be back, Chairman.
Yep.
Thank you, Chairman. Timothy Hill, 3rd House District, which is all of Johnson County, part of Carter, part of Sullivan, and part of Hawkins County. And Chairman, it's a delight to be back with you again this year.
Thank you, Mr. Chairman. I'm Brock Martin. I represent Gibson, Carroll, and Henderson counties, kind of right in the middle of the heart of West Tennessee. My wife and I have a 9-year-old, a 1-year-old, and she is due in April. So if we can get out of here by April, I can go home and see my child being born. So there we go.
Good morning. My name is Renee Jones, and I represent District 4, which is Carter and Unicoi County, and it is great to be back. Thank you.
Good morning, Representative Harold Love, District 58 in Nashville, which is part of the central core of the city, and elected in 2012. So glad to be on Insurance Committee again. My wife and I have been married for a few years now. We're still enjoying each other. So glad to be back this year, Mr. Chairman.
Good morning. State Representative Yusuf Hakeem from Chattanooga, Tennessee, in the central part of Chattanooga. My wife and I have been together for 60 years. And we have 4 children, 4 grandchildren, and 4 great-grandchildren. So it's a lot of Hakeems running around there. Thank you, Mr. Chairman.
My name is Scott Zipicki. I represent Murray County, which is the eastern part of Murray County. I've been serving on the Insurance Committee, I think, for 7-8 years now. It's an honor and privilege to be here. I've been married for 28 years. I have 2 boys, and we spend most of our time running from college to college for football games. So enjoy being on insurance. It's always thrilling and exciting, and I'm glad to know we have a Sergeant at Arms that I feel very safe with. So thank you.
Go ahead.
Name's Andrew Gunner. I am a House Bill Clerk.
My name is Sarah Fisher. I am a House Bill Clerk.
That completes the roster, but we also have an intern in the committee, Ms. Hannah Ramos. Thank you. It seems that the matrimonial status became almost a badge of honor, and I forgot to mention, and if my wife is watching, that can that can matter a lot. Right. I've been married for 44 years to the fabulous Linda Kumar. We don't have grandchildren yet, and that completes the introductions, I believe. Somebody wants to add. On our calendar today is, we thank you for having recorded the roll, but it still has to be officially called by the clerks. Please do call the roll. For the record, Chairman Lafferty is excused. Can we move on with the business now? Clerk, please take the roll.
Mr. Chairman, you have 16 members present. You have a quorum.
Thank you. So, the sole item on our agenda today is a presentation from the Department of TennCare. And gentlemen, please come on up and take your seat. Identify yourself for the record, and we will go out of session.
Thank you very much, Mr. Chairman and members. Happy New Year. It's good to be with you all again today to provide a update on TennCare, much like we did last year around this time. My name is Stephen Smith. I serve as the TennCare Director. To my left is Zane Seals, our Chief Financial Officer. And then to my right, we have Dr. Victor Wu, our Chief Medical Officer. And to his right, Katie Evans, our Chief of Long-Term Services and Support. And we have others in the audience as well. As this committee well knows, our state has a very long and complex history when it comes to our Medicaid program. It is one that is filled with tremendous challenges, but also achievements as we have strived to meet our mission of improving lives through high quality, cost-effective care. The fact is, TennCare is more successful today than at any point in its 30-year history. It's a remarkable turnaround story. It's one that required difficult work and perseverance from many people and leaders over multiple decades, none more important than this committee and the General Assembly. Those efforts took us from a place where the TennCare budget was literally going to take every available new state revenue dollar to one where we now have record investments in TennCare, while at the same time having record investments in public education and all of the other priorities within state government. That is not a coincidence. It's why we take so seriously this idea that TennCare is about so much more than just the TennCare program itself. The success of a state depends upon the success of its Medicaid program, and you can look across the country right now as evidence of that fact. As we enter the last year of this administration, we are proud to note that we have only gotten stronger over these last 7 years, despite the highly unusual and unpredictable events that impacted us all. As you can see, trend rates continue to improve, as do investments and quality. No one could have reasonably predicted that back in 2020. Perhaps there is no greater evidence or confirmation of our program's success than our most recent innovation known as TennCare 3, which all started as a very bold idea and concept from the General Assembly. I told the Finance Committee back in November, I will always take pride in the fact that we didn't just take your directive back in 2019 to pursue a block grant and just go through the motions with the thought that it would be impossible. Instead, with the governor's leadership, we gave it 100%, and we landed a deal that had never been achieved or even attempted, and to this day has not been replicated. It's a shared savings model that rewards Tennessee for its conservative, effective, and responsible management of its Medicaid program. We were as you all know, we were absolutely confident in our in the deal that we structured and our ability to be successful. But I would be lying to you if I sat here today and told you I thought that we would achieve these type of results in such a short period of time. Since the inception of this waiver, we have had the largest TennCare investments than any other period in Tennessee's history. Just a couple of the highlights. We've added a comprehensive adult dental program for the first time in Tennessee's history. We've added thousands of additional seniors and Tennesseans with disabilities through our ECF Choices and our Choices program, as well as our Katie Beckett program. We have more to be added this year, thanks to your support. We have added thousands of additional children and pregnant women and parents that have been served through our Strong Families Initiative and Year One Shared Savings. We have invested or committed to invest $100 million for behavioral health and $200 million for rural health through our Year Two Shared Savings. With Year Three Shared Savings, in addition to the significant investments in long-term care, we provided $100 million in immediate assistance to those communities devastated by Hurricane Helene. In just the first 3 years of this 10-year waiver, we have achieved and secured $1 billion. And as we committed to do from day one in partnership with the General Assembly, we have reinvested these funds in ways to improve the lives of the people that we serve. Really, the most important thing that I can say to you all today is thank you. Thank you for pushing us. Thank you for taking a risk with us. I know that there were a lot of people telling you to reject our proposal back in January of 2021. You had the confidence in us to get this right, and it has paid huge dividends for the people that we serve. And we've done it at no additional Tennessee taxpayer expense. That is really an incredible accomplishment. But it's important for me to stress that it's not a TennCare accomplishment. It is a Tennessee accomplishment, one that we can all be proud of because it doesn't happen without everyone involved, from government to our health plans, to our many stakeholders, and to our medical professionals and providers who make that direct connection with the people that we serve every single day. These are not just numbers. They represent real people, real lives, and real futures. And there are stories behind every one of these investments. Shifting specifically to provider investments, the numbers here are, they're really staggering, and they're beyond anything that we have seen over the course of any administration. More than $5 billion in additional combined state, federal, and assessment funding to providers. Even more if you consider the cumulative impact of recurring investments. And that is in addition to the rate increases that are provided through our normal managed care operations. That includes more than $4 billion for hospitals, $700 million for nursing homes. When it comes to physician payments, if you look at the last 5 years, we have averaged an annual rate increase of 3.5% compared to the national average of less than 2%. And this has occurred while Medicare rates for physicians have now been cut for 5 years in a row. For behavioral health, it's a 6% average over the last 5 years on record. And I understand there are and there always will be challenges and debate when it comes to Medicaid provider payments. The debate that we have here in Tennessee is no different than any other state or Medicaid program throughout the country, regardless of what those states may pay. It is always a challenge when it's taxpayer funding that is responsible for the costs that are rising at unsustainable levels. And we are seeing that play out at the federal government as we speak. But the point is this, here in Tennessee, when we look at our Medicaid investments, it is indisputable that they exceed anything that has ever been seen in our state. And it's really not even close. We have tremendous relationships with our providers, and I have so much respect and gratitude for the work that they do every day to serve our TennCare members. Without them, all the success that I've already highlighted, it just wouldn't be possible. The fact is, we want to pay our providers as much as we possibly can. And I believe when you consider all the responsibilities that we have as an agency to the state and to its taxpayers, along with the health of our provider network, that we are doing just that. All of this is direct proof of what we talk about all the time. Those two pillars of our mission, quality and cost effectiveness, they go hand in hand. They are dependent upon one another. The entire concept of our TennCare 3 waiver is that we keep cost growth to a reasonable level. We achieve shared savings. We reinvest those savings in ways to improve health, which drives down costs, which results in more shared savings. So it's really a cycle, and that cycle is designed to start all over again. I want to stress the success and stability that we have today within our TennCare program. It's not normal. It is a very difficult time in Medicaid throughout the country. Across the nation, states have cut provider payments or services, or they are considering doing so. In some cases, across the board provider rate cuts as high as 10%. We don't anticipate that happening here in Tennessee. And why is that? It's because we have been responsible. One of the most important things, and we did this together, is during the pandemic, when we were receiving enhanced federal funding, we separated the anticipated non-recurring costs that were incurred from increased enrollment, and we used those enhanced federal dollars to cover those costs. At the same time, we continued to ask for and receive the typical cost increases associated with what we believed would be the normal population post-pandemic. So thank you very much for that. Many states didn't do that, and they are now facing the consequences. Because we did, we were able to fund our non-recurring expenses. We were able to make large reversions that helped the state's general fund when it was desperately needed. We were able to meet our long-term obligations, and we came out of the pandemic with no large gap to fill. That takes great forecasting. It takes great planning. It also takes strong leadership and self-control from everyone involved in the budget process. Most importantly, the legislative branch, which ultimately determines our budget and our spending. Before I leave this subject, I want to highlight our enrollment since 2020 because I think it represents what I just talked about in terms of the importance of planning and forecasting and budgeting. What you see here is a sharp increase in our enrollment while the federal pause and redeterminations was in effect. We went from about 1.4 million to 1.8 million, and then you'll see a gradual decline as those redeterminations started once the federal government permitted us to do that. As you can see, TennCare never had to pause our redeterminations. And to put that in perspective, if we did have to pause for several months, and many states did have to do that, that would have been an additional cost to the state of hundreds of millions of dollars. Just a 6-month pause would be more than $450 million in state obligations. That's hundreds of millions that would not have been available to do many of the things accomplished in recent budgets, both inside and outside of TennCare. Before I leave the subject of enrollment, I want to acknowledge that Medicaid programs, including TennCare, we spend a lot of time talking about how to help people get onto Medicaid. And those are important conversations to have. But I believe we need to spend more time talking about how we can transition people off of Medicaid, not in a punitive way, but one where we can encourage and incentivize people to improve their own lives through work, through better jobs and higher pay so that they don't need Medicaid and that they can create a pathway to independence for themselves. We should be thinking about ways that we can help people with that transition so they don't find themselves right back on TennCare or Medicaid after a short period of time. That is good for the people that we serve and is good for the taxpayers that fund our program. So in the coming days and weeks, we look forward to working with the General Assembly to explore this concept and this idea more. At the chairman's request, I'd like to shift to the subject of the TennCare reserve. I know there have been a lot of questions about our reserve, and that's certainly understandable when you look at the size of our reserve. It's a large number. But it's important for me to stress that that large overall number does not represent our true emergency fund when you consider the large amount of obligated funds, primarily through our shared savings investments. or initiatives. As you can see, as we have proposed through each of the last 3 years, shared savings commitments encompass a very large percentage of the total reserve amount. And then there are other obligations that bring that total to $1.2 billion of the roughly $1.4 billion total reserve amount. So when you're looking at those obligations or those shared savings dollars, it's about 86% of the total. However, when you look at truly unobligated non-shared savings funds, the amount is only $190 million. Just to put that in some perspective, that represents only 4 days of TennCare operations if we're looking at state funding only. If you add the federal match, it's about 11 days of TennCare operations. And then just for a historical view, since the inception of the TennCare reserve, the truly unobligated amount has averaged about 4% of the TennCare budget. Today, we sit at 1%. So when you take all that into consideration, we believe that our reserve is certainly not excessive, but we're happy to talk more about that. As you all know, there's been a lot of discussion around health insurance at the federal level recently, including Medicaid. Many of the things coming after the passage of the One Big Beautiful Bill. Considering the time, I'll save the detailed discussion for the Q&A if you all would like, but just the top line message here is that we are well positioned relative to other states to deal with the impact and the changes that are coming with that legislation. While determining the exact impact to TennCare will not be possible until CMS puts out its final guidance, I do want to clarify just a couple of things. First, on eligibility, the provisions affect expansion states and the expansion population primarily. Because Tennessee is not a Medicaid expansion state, there is minimal eligibility impact. Moving to provider payments, beginning in 2028, the law introduces new limits on provider taxes and directed payments to certain providers. For us, that includes hospitals, EMS, academic physician practices, and nursing facilities. Again, until we get that final guidance, we can't give you an exact forecasting of what that is going to look like. But we do know that there will be an impact. On a very positive note, the legislation included the Rural Health Transformation Program to address rural health challenges. The program provides $50 billion nationwide in funding over 5 years to support initiatives aimed at improving rural health care. In late December, we received the very good news as a state that Tennessee was approved for $207 million for the first year. So that is a tremendous outcome and opportunity to improve health in our rural communities. Most likely, you all have seen recent national reporting around provider fraud within social service programs in other states. I want to assure you all that we have a very robust multi-agency system here in Tennessee to attack fraud. It is a true collaboration among TennCare, OIG within FNA, the TBI, and the Attorney General. We're happy to talk more about that, but we have been aggressive and we use the tools and the resources that have been provided to us through multiple agencies and efforts. I'll close with this. I spent a lot of time giving you all what we consider good evidence of our success, but there is no better gauge of our success than our own members' opinions. As many of you all know, we talk about this every year, but the University of Tennessee conducts an annual survey of Tennesseans' satisfaction with their health insurance plans. In the most recent survey, TennCare received a 97% satisfaction rate. If you go back to 2020, we have never fallen below 92%. And this is what I think is maybe the most noteworthy point about this survey. During this period of 2020 to today, for the first time in the survey's history, reported quality of care for Tennessee households and their children, for TennCare households and their children, met or exceeded reported quality of care for all Tennessee households. And that includes private commercial insurance plans. So we stack up really well when you're comparing us to our commercial plans throughout this state. And then finally, I want to acknowledge that despite the accomplishments that I noted today, we know that we must continue to improve. Medicaid is difficult. We know that our challenges are not going to get any easier in the coming years. So that TennCare turnaround story that I mentioned earlier, that story is not over. This may be the last year of this administration, but we have much more to do, and we look forward to closing strong. So thank you, Mr. Chairman. Happy to address any questions you all have.
Thank you, Commissioner Smith. Members, do we have questions for our guests? Representative Hakeem, you're recognized.
Oh, okay. Thank you, Mr. Chairman, and thank you, sir, for the presentation you made and the efforts that you and your team have made over these years. We greatly appreciate it. A couple of questions I have. One, without the infusion of dollars during the pandemic, you have any idea what your numbers would look like?
Well, we know how many dollars we received during that time, and we can speak to that. The caveat with that, I would say, though, is that the federal government prohibited us from going through our normal eligibility determination process, and so most of those dollars, or certainly a very large portion of those dollars, were to pay for the increased enrollment that was mandated by the federal government. But Zane, do you have a number?
Zane Sills, Chief Financial Officer. So over the course of the federal public health emergency, because of those requirements by the federal government, we had to spend an additional nearly $1.2 billion in state portion. If you add in the federal portion, it's a little over $4 billion in total. Again, we did receive the enhanced FMAP from the federal government as recognition that they were putting additional mandates on us. So we did receive enough in the 6.2% to cover all of those costs. But over the 4 years, it did total to about $1.2 billion in state dollars.
But the fact is, we actually received more money from the federal government than what we needed. And that's why we had those large reversions that I mentioned. I mean, you talked about reversions earlier. We had some pretty large reversions. I think we talked about those in this committee. Very unusual. And the reason why is because we received more federal dollars than what we needed to meet the demands of the increased enrollment.
You're recognized.
Thank you, Mr. Chairman. If I may, I have two brief questions more. One, you spoke of persons. I couldn't remember if they were potentially being taken off of Medicaid, but I guess one of the provisions that were being looked at was more people going to work. And do we take into consideration their physical well-being? You know, I guess a person on diabetes and other elements and so forth. Are these type persons going to be required to, quote, find a job?
Well, you may be referring to the federal community engagement requirements, and there are exceptions for individuals, for example, that have a disability. What we're really talking about here, what I was talking about, are able-bodied individuals, and separate from the federal requirements. What we are really talking about is, are there things that we can do within TennCare and as a state to incentivize people to either go to work, but a lot of our members are already working, but they may have a disincentive to take a higher paying job because then we have the benefits cliff and they're going to lose their Medicaid. So are there things that we can do to help with that transition? And the purpose of that would be to help them to make that choice to better their own lives, but also prevent that churn from them coming right back on to Medicaid maybe a few months after they exceed that income limit. It's really designed as trying to help them achieve that pathway to independence.
Okay, one last question, Mr. Chairman. Nonprofit providers, have they been squeezed to the point where it's difficult for them to provide any services or can't provide services anymore because of, quote, we want to have savings to I guess give the good reports.
Well, I do want to clarify that the shared savings that I mentioned per our waiver, when we designed and negotiated with the federal government on that waiver, really all we had to do was continue to do the things that we've always done, which is be responsible, which is be conservative. We didn't have to. We're not getting shared savings by cutting rates. In fact, as I mentioned, we've improved rates. We put more dollars into provider investments than at any point in history, and yet we've still achieved massive shared savings numbers. We have not seen an exodus of providers from our network, and that would apply also to our nonprofit providers. So we are not seeing that. I don't believe that we are squeezing out nonprofit providers.
Okay. Thank you, Mr. Chairman.
You're welcome. Representative Love, you're recognized.
Thank you, Mr. Chairman. Thank you, Commissioner, for your presentation. I did have a few questions about the effect of the federal legislation upon our Medicaid program. And I know you said they were still waiting on the guidance from the federal government. So first question, is there an expected date when the guidance will be given?
Somebody can correct me if I'm wrong, but I think we are expecting the guidance. I think they have to provide guidance by June. Now, whether they will do that beforehand, that would be great if they do, but I think the deadline is June.
Okay. Thank you, Mr. Chairman. Also, so is there I know you can't give them an exact number because you're still waiting on guidance, but is there a projected amount of reduction of federal funds for our program based upon what you have seen so far?
It's very, very difficult to give a projection, and I can kind of give you the top line here. So when we look at our providers that are impacted by the directed payment requirement, so it's just hospitals, that's probably the largest provider group that we're talking about here. The federal requirements are that starting in 2028, we have to reduce those payments by 10% a year until we get down to 110% of Medicare rates. Now, you all probably are aware that we just made a record investment to hospitals through the hospital assessment in partnership with the Hospital Association and the General Assembly and our partners at the federal level. It's a massive infusion of dollars. And so right now, our hospitals are receiving more money than they ever have from TennCare by far. Starting in 2028, if things stay as they are, we're going to have to start reducing those payments by 10% a year. It's based on the Medicare rate. We know Medicare, there tends to be an increase every single year. And so it's just really hard to know when we get 10 years out where we're going to be relative to where we are now. I wish I could give you a better projection, but it's impossible to do it.
Okay. One more, if I could, Mr. Chairman.
Just to clarify, sure, in a moment. When you're saying the 10% reduction, does that apply to rates paid to the hospitals for particular services or the total amount paid?
So that applies to the total amount of the hospital improvement program. It's a directed payment that goes out in lump sum quarterly payments that's above and on top of what our managed care organizations pay as negotiated rates for services. So the reduction will start with those essentially lump sum quarterly payments in 2028.
Thank you. Representative Love, you're recognized.
Thank you. Last question here. Shared savings program. I'm glad to see all of the reinvestments in the state. The question I have, though, is this. The shared savings allocation. What is the process for determining where the shared savings get allocated? Is it a committee that meets in Cordell Hall, or is it a committee that meets someplace else, or what? Or is it you identify the most pressing needs? So please,
yeah,
if you can expound upon that.
Well, thank you for the question. It's it's actually the same process that we go through with any of our budget requests. So, of course, we work internally, we work through the governor, and then we bring those ideas to you for final approval. So you'll see, for example, when the budget comes out, we will have our year 4 proposal before this body to determine how we allocate those dollars.
Okay, thank you, Commissioner. Thank you, Chairman.
Thank you. Representative Martin, you recognize.
Thank you, Chairman. Thank you, Commissioner, and your team for all you're doing for Tennesseans. If you're okay, I got several questions and I want a couple of comments. So the past 8 months I've spent in my district going out, meeting with provider groups. I'm on the provider side, asking them what's going on, what they're experiencing, what's truly happening in regards to that. So this is all geared mostly towards that, and MCO conversations especially. The number one issue I continued to hear was the lack of workability within MCOs in those individual provider groups. Not necessarily reimbursement, which might be a surprise, but just operating, doing business in Tennessee with those individuals. So from the point of the committee, can you explain, or whomever, how many MCOs do we currently have in Tennessee?
We have three MCOs.
And how long have each one of those been in contract with Tennessee?
It's been a long time with these same 3. We went through a procurement back in 2021. That was the last procurement. That's now tied up in the courts still. But we've had those same 3 for since like 2010.
Yeah, a good while. And then from a taxpayer standpoint, how much operating budget do we give the MCOs to manage taxpayer dollars to run our system?
Yeah.
Do we have an idea?
Yeah, we probably have that.
Thanks. The MCO line item of our budget is approximately $12.3 billion.
$12.3 billion.
Yes,
Yeah.
but keep in mind, that doesn't mean the MCOs
Oh,
are,
yeah,
that's to,
absolutely. No, I'm just painting a picture that mostly. I mean, thankfully I was served on this as vice chair a couple of years ago, so I got to learn a little bit about how this operates. But I'm hearing that. That's why I wanted to bring that up. We're hearing that when I'm in my communities, is that's an issue. These guys aren't necessarily reimbursement component, but on the business side of how they're creating barriers sometimes. Case in point, who's in charge of making sure contracts are up to par or up to standard in between the provider group and the MCOs? Didn't care have any oversight over that, or is that strictly between the MCO and the provider?
well, we have the contracts with the MCOs, of course, and then they do have to meet certain requirements per that contract, and there are pieces of that contract that would apply to the individual agreements with the providers. But our MCOs are at risk, and they are charged with building the provider network and negotiating those individual contracts with providers. And we've talked before. We don't tell our MCOs what to pay or what to negotiate. That kind of would go against the concept of managed care operations, which we believe have been probably the primary driver of our success. But our MCOs do need to communicate with our providers. They need to be responsive to our providers. And when that doesn't happen, we want to know about it, and we will have discussions with our MCOs.
Yes, sir. I think that's fair. And just to preface this a little bit, I've got a great relationship with those guys that work for those MCOs. I can call them and they can get it done. But in case in point, this one specifically that I met with just recently, I said, I'm not going to say anything. Let's see what happens. See it play out. And this was a contract issue. They started back in April, this group. It is January 20th. They still don't have their new contract available yet. They're still operating on last year's contract component with the MCO, which is fine if that's how they want to operate. But that's an issue, because that's taxpayer dollars that we're still not getting correctly fitted up, not getting that conversation there. And then it's impacting barriers of care. So with that specific company, they have that issue. Their private insurer is through that same MCO's big corporate company. They went up 40% this year on them. And that's a big deal in small town businesses where they're going up 40%, but then they can't even get the MCO to come to the table and negotiate correctly with a new contract with them to get it for January 1 when they told them they had to do their part. So since April, they haven't had very much communication with those guys. And that's frustrating, as Small business guys, because this is a business-friendly state, and it's not always just about reimbursement when it comes to providers. It's creating that communication where we are working together for a patient-centric approach. So I just wanted to bring that to light to this committee. Those are things we're hearing, and that's not to blame any of their government operations people. I mean, again, I could have made a phone call and it probably been done the next day because that's how they operate, thankfully. But it shouldn't take a legislator to call on behalf of those companies because not everybody's got Brock's cell phone where they can reach out to me. So that's a big issue that we need to at least work on communication or ask communication from TennCare with those MCOs. If we're going to have the same three that are doing a good job, let's do it better for businesses for Tennessee as well. So thank you.
Well, thank you. Chairman Terry, you're recognized.
Thank you, Chairman, and thank you, Director and team, for coming here. And I've got a few questions and some that are topical and some to kind of follow up on what the Chairman had just talked about. But, I've obviously with some things that have gone on the news, you had a slide there about fraud. And I've received some inquiries, obviously, about fraud as it does with services as well. And with what's going on with illegal immigration as well. Could you discuss from how much fraudulent enrollment you might have, or you said you've got a pretty robust team from that, and then could you also address if there are any illegal immigrants receiving any TennCare benefits?
Sure. I take the second question first. That's an easy one. We are prohibited from serving anyone here illegally within the Medicaid program, and so that should not be happening. I don't believe that it is happening. I'm sorry, can you repeat the first question about fraud?
Yeah, and again, appreciate your answer to that because I wanted you to get on the record because that's the answer that I had received, but it's still out there that you are giving those type of benefits, and I wanted to make sure you had that on the record. But as far as just fraudulent enrollment, those that shouldn't be on the records that currently are.
Okay, gotcha. So what we were referring to in the slides really provider fraud because that's where most of the recent activity has been. We also do have instances of member fraud, and member fraud is actually addressed by OIG within FNA, and they are very aggressive. And so I think we do really well as a state with catching that and identifying it and then taking swift action. In terms of the number of individuals, we could get back to you on that and see how many we've had, and we could pull it from the last 3 or 4 years and see how many convictions we've had.
Okay, appreciate that.
Yeah.
Okay, thank you. And kind of to follow up on what the chairman had been asking as far as the working with the MCOs, and you talked in your slides about payments, and it talked about the shared savings, but obviously with rural health transformation being in the news and obviously going to be a hot topic, and again talking about Medicare rates and the cutting down from that. When it comes to providers, oftentimes the Medicare or the Medicaid or the TennCare rates are a fraction of what the Medicare rates actually are. So it may be a third sometimes of what Medicare rates are to the providers. What are we doing, or what can TennCare do? You say that you allow the MCOs to have these contracts, but what can you do to improve this disparity, particularly in rural areas, because the payer mix in rural areas are predominantly TennCare?
Mm-hmm. Well, again, it is a challenge. I think, particularly for physicians, again, if we look at the past 5 years on record, we are in Tennessee, we are exceeding the national average in terms of our rate increases for physicians. The Rural Health Transformation Program, it does allow us to, I think, tackle access in rural areas. It does not allow us, and we're actually specifically prohibited from using those funds to increase provider rates. So we can't use the Rural Health Transformation Program funds to do that. again, it is a very difficult time in Medicaid. You look across the country, and so many states are actually talking about across the board rate cuts. We are not doing that. But also it is a very challenging time. And it is going to be difficult to, maybe more so than recent years in terms of rates. And I want to be honest and transparent about that. It doesn't mean that we won't have rate increases, because I think we will. We'll have those through our managed care operations. We will let the market drive where those rate increases need to be. But I'll say it again. It's a challenging time in Medicaid, and we're no exception.
All right. Thank you for that. I have one more question, and this goes to, again, kind of working with the MCOs from a provider standpoint. I'm sure you're aware that we had an issue in my county, and one of the MCOs the providers could not come to an agreement with them. And I just want to make this for the committee to be aware of. The contract, I guess, ended the end of December, and those patients essentially had to find another provider. Apparently, their re-enrollment comes in May, and so there's a gap. So if they wanted to stay with the providers that they were at, it would be May before they could. So they're out essentially 5 months. The providers tried to get an extension, just allow the contract to go to 5 months. So there's a discrepancy of when their contract ends versus when re-enrollment begins. And so it's putting a lot of patients out. They're trying to scramble to find another provider for these 5 months. If they need to come back, those providers are having to, they had thousands of appointments that they're having to change. And so I guess from our standpoint, I wanted to bring that to everybody's awareness, but is this something that matching these up where it's re-enrollment with their contracts? Is that something that can be done in rules? Is that something that requires legislation? How do we get that so that we don't put our patients out for a period of time?
Yeah, we can take a look at that. Right now, the re-enrollment period, there's one for West, there's one for Middle, and there's one for East. One thing that I do want to note is it is the responsibility of that MCO to ensure that every single one of those members has access to a provider. That is their responsibility. And if that's not happening, then we certainly want to know about it, and we will address it. It's my understanding that is happening, and that's part of their contract. They have to provide an adequate network, and in cases where we have members that are seeing a particular provider, and that provider is no longer in the network, then it's their responsibility to make sure that there is access with another provider. But in terms of, I don't know how complicated it would be I think it'd be very, very difficult to establish a separate enrollment period for every contract end date. I don't think that would be feasible. I don't even know if that would be allowable, but we could look at the timing of those and get back to you.
Go ahead. One more question, and you brought about network adequacy, and that's, if you can get me some information on, we're kicking the training wheels back off, getting back into session here, but about network adequacy and what's going on, because from a patient perspective, this group had a lot of pediatricians. And obviously with their well child visits and this, that, and the other. And even though it says there's an adequate network, when you lose that many providers, obviously you're pushing these patients out. They can't get into somebody. And while they might have an adequate number based on paper, that's not an adequate number of slots that they can see these patients, and they're getting pushed out. So if you can get that information to me sometime soon.
Sure.
Thank you.
Thank you, Mr. Chairman. To follow up on Dr. Terry's point, So those who are here in the country, undocumented or illegal, they do not qualify for TennCare, right?
Correct.
Under what circumstances can they qualify? If they get themselves a work permit to drive a truck, can they qualify?
Well, so let me, because the One Big Beautiful Bill also made some changes around this. So, so for example, well, actually today, non-citizens that have been granted asylum are eligible. Now, we're not talking about illegal here. We're talking about non-citizens that have been granted
Right, they're no
asylum.
longer illegal.
Starting October 1st, 2026, that will no longer be the case. Same thing is true for refugees. So currently, someone who has been admitted to the United States as a refugee can qualify for Medicaid if they fit within a Medicaid category. But after October 1st, 2026, refugees will no longer be eligible. I probably do need to make a clarification. We have Medicaid, but we also have the CHIP program, which is kind of separate
Right.
from Medicaid, but we kind of treat it, when we talk about TennCare, we kind of treat it as the same. There are situations where you may have a pregnant woman and services to the child, the unborn child, are provided. And so I want to make that clarification and be very transparent about that. That's specifically CHIP. It's not Medicaid.
True, but that is, that does apply to a person who's here illegally.
It could, yes.
They could do that. Does the federal government at any time mandate to you that these people, this particular group has to be covered?
On the CHIP side?
Or the Medicaid side?
On the Medicaid side, it's prohibited. On the CHIP side, we're looking into this. We're looking into whether if, for example, you all decided, or we decided internally that we no longer wanted to cover the unborn child services related to the unborn child, whether we could do that.
And are there allowances for people coming from particular countries at any time?
There are right now. Again, after October 1st, 2026, that's very, very, very limited.
Okay, that clarifies, because when people ask, we are not able to give them a straightforward answer because there's so many exceptions built in. Just for those of us who don't deal with it every day, just clarify the status of certain programs that you mentioned in TennCare, being Katie Beckett, Strong Families, and the HEAL program.
Mm-hmm.
Tell us what the acronyms mean and what is their status.
So the Katie Beckett program, let me get the numbers here. Okay, so currently within Katie Beckett, and Katie Beckett is a program that is designed to benefit children with extremely complex needs. It was an initiative from this General Assembly, and it disregards income. And so it is a real life changer for the people that receive those benefits. We currently have about 5,000 children that are enrolled in Katie Beckett. That includes both Part A and Part B. Part A is run through TennCare. It is the most children with the most significant needs. Part B is run through our Department of Disability and Aging. But total, we have 5,000. That actually exceeds the original numbers, which were at about 3,000. That was the projection. We've been able to serve many more than the original 3,000. We didn't know how much this was going to cost when we started doing it. The costs have actually been lower than anticipated in total, and that allowed us to serve more people within the existing resources. But with that said, we now have, essentially, we have a waiting list in both parts. So we're not quite there yet in Part A, but we're going to be there very, very, very soon. Part B, we're already exceeding the demand. So there is a wait list. but we're restricted to operate within existing resources. But it's been a very, very popular program. It's been a very successful program. The HEAL program, this was in response to Hurricane Helene. I'm trying to remember what the acronym what that stands for. And I'm drawing a blank.
Helene emergency something.
Yes, yes. But we were very proud to be able to use shared savings, $100 million that we provided to TEMA, and then TEMA provided grants to the counties that were impacted. And of course, we felt like that was a very appropriate use of those dollars because we have a large percentage of individuals in those counties that are TennCare members. It actually exceeds the state average. And those dollars were used for water treatment and debris removal. And so what's more important to someone's health than having access to clean water and having access to a provider, being able to get to see their providers. And so those dollars have been distributed, and by all accounts, that has gone very, very well. Did that cover all of it, Mr. Chairman?
Strong families.
Oh, strong families. So strong families, that was year one shared savings. What that allowed us to do was to provide benefits, postpartum benefits for our pregnant women. We provided continuous coverage up to a year for children. We increased the income cap for our parents, we were roughly at about 83% of poverty. This allowed us to go up to 100% of poverty for our parents, which is really important because that closed the coverage gap. Because in order to be eligible for a subsidy on the insurance exchange, an individual has to be between 100% and 400% of poverty. So previously, we had parents on Medicaid TennCare that were above 85% of poverty, but below 100% of poverty. And there really was no option for them because they were not eligible for TennCare and they couldn't get help with the subsidy on the insurance exchange. And so by going up to 100%, that really allowed us to support parents here in Tennessee. So we have, we've added, that allowed us to fund more than 25,000 people in total. And we're using those shared savings to actually buy back the recurring state dollars that were appropriated for that purpose. So, of course, those are recurring expenses. Shared savings are non-recurring. And so what we did back in that first year is we came to the General Assembly, we asked for recurring dollars for that, and then we're using the shared savings to buy back those recurring dollars. And that's how that works. But that's kind of the status on the strong families.
Well, thank you. Chairman Martin, did you want to follow up?
Hold on.
Okay, thank you. Yes, we have other people on the list. Chairman Grills, you're recognized.
Thank you, Mr. Chairman. And just real quick here, you brought up those refugees. If you don't mind, just how many refugees do we have on the TennCare rolls? How much is it costing Tennesseans? Who determines what a refugee is?
Well, the refugee status is determined by the federal government. So we don't have a say in that. Let's see. If we look at the most recent year, if I'm looking at qualified non-citizens, we had 8,051 people that had paid claims. And that the last year that we have on record is 2024. We'll be able to pull calendar year 25 soon, but that's the last year. And then the year before is roughly around 8,000 as well.
Okay, so that's a running number. All right. You had the waste, fraud, and abuse slide up there a few minutes ago.
Mm-hmm.
And of the different states that are around us, do we have a good working relationship with the other states to see if we have people who are living in other states that are taking advantage of our services, but they don't reside in Tennessee?
Yes, we do. And that's actually something that is also was tackled by the One Big Beautiful Bill. The federal government is going to be establishing a system that's going to make it much easier for states to be able to quickly identify when that occurs. Because sometimes there's a delay and we don't get that data. It may be a couple of months out, but the way the system is supposed to be designed, we're going to know instantly. And so we'll be able to communicate and know instantly when that happens so that we can cut off those benefits.
Okay. Thank you, Mr. Chairman.
On a simpler level, what is the daily cost of TennCare to the state of Tennessee? You can take the budget and divide
the
it by
calculator out.
365.
It's a lot.
It's about 50 million a day.
50 million there.
And that would be state and federal.
Yep.
And state and federal is a 3-to-1 match or 2-to-1?
Roughly 2-to-1, so it's about 35-65.
Well, thank you. Representative Hakeem, you recognize, sir.
Thank you, Mr. Chairman. I have two brief questions, if I may. One, we were talking earlier about, I'm going to use the term able-bodied persons who are on Medicaid. In our current economic environment, there are a lot of people who are out of jobs. And if these persons have not had a job for a period of time, how likely are they to get a job in this current environment? And do we still hold them? If you don't get a job, you don't get Medicaid in this current environment.
Well, I think two different buckets here to consider. So there's the federal law, which has some certain community engagement requirements. And for us, as I mentioned, there'll be less of an impact for us because we are a non-expansion state. We may possibly have a very, very small number of individuals that will be impacted by that. We're still working through that with CMS. But then we have what I was talking about. What we want to take a look at is trying to help people with that transition, and that's more about helping them better themselves. And so part of that, though, is working with our Department of Labor and Workforce Development, working with our team over at DHS to connect them to available jobs and job training so that they can take that leap. Again, we have a lot of our Medicaid members today that are working, but perhaps they're not taking a higher paying job or accepting a promotion because they're worried about losing their TennCare benefits. And we want to explore, are there things that we can do to help them make that transition?
Okay, and lastly, there are, you spoke of, well, let's use the CHIPS program. If there are changes in that program as far as eligibility is concerned, is that a decision that's purely done by the administration or your department, or is the legislature involved in that?
Well, we are looking at, we need to look at first what's required at the federal level. But ultimately, if the federal level allows the state to make that determination, then I guess it could happen both ways. We could do it. We'd have to go through the rulemaking process, which you would have a say over. Or, of course, you all could direct us to do something different.
Thank you very much.
Chairman Spicky, finally, it's your turn.
Thank you, Mr. Sorry, I've been sitting here for a while. Thank you all for being here today. I've been sitting through these presentations for a while, and some things change, some things don't change. And so I have a couple of questions off some things. You stated $50 million a day it costs to operate TennCare. Is that strictly claims that are paid to providers, or are operational costs of the MCOs included in that?
That would be total. So it would include everything. So we have a roughly $18 billion budget in I think you probably just did the math and
52 million a day.
So
Yeah, and that includes everything.
So at $52 million a day, can you tell the committee what the operational costs of that 52 million are to our MCOs? What we pay our MCOs to be MCOs in Tennessee? What percentage of that 52 million is paid directly to them for operating costs?
Generally, our MCOs run an operating budget of a little less than 10% of their total funds. So that's going to be right in the neighborhood of 800 to 900 million a year.
And that's divided by 3 MCOs?
Divided by 3 MCOs.
Based off their population of people that they serve?
Based on, yeah, the administrative costs are paid out on a per person basis. So we have actuarially sound capitation rates set by actuaries. It's the exact same thing as an insurance premium, right? And so that includes a monthly PMPM that's mostly for medical care, and then a little less than 10% is admin.
And what was the number you had per year? What was the number you gave me?
Between 800 and 900 million across the 3 MCOs.
All right, thank you. When an MCO terminates a contract with a hospital, is TennCare notified?
yes.
And does TennCare have an oversight on that to say, no, you're not going to terminate that contract? You're going to keep it in place because we believe in TennCare that you're not going to create adequate coverage?
Well, we do not, actually contractually, we can't tell the MCO that, no, you must continue to contract with this particular provider. Now they have to meet network adequacy. So if there's a network adequacy issue, we're going to have a lot of discussions about that. But there's not a situation where, unless there's a network adequacy issue, that we would say or be able to say, no, you must contract with this particular hospital or this particular provider.
So if an MCO determines who they contract with based off of the negotiated contract that they have, what prevents an MCO from being heavy-handed with their negotiations on what they're going to pay if there's no oversight to the MCO on those contracts?
Well, there is oversight because, again, there'd be oversight by us. But to your specific question, you are asking, would we step in and say, MCO, you must negotiate with hospital. You must contract, you must meet the demand of this particular hospital. And we don't do that. But what's going to hold them accountable is that network adequacy piece. And we're going to have to make sure that our members can have access to a hospital.
So an example would be Murray Regional is contracted with TennCare. There's a new hospital going in Spring Hill, which is 17 miles away. Because that new hospital is going in, if they contract with that new hospital in Spring Hill, now it creates an opening for the MCO to negotiate cheaper rates for Murray Regional, because they could cut the contract with Murray Regional and go at the Spring Hill Hospital because it's in a close proximity. Now you create an issue there at Murray Regional where they could be forced by the MCO to take a negotiated less payments for their services because of the threat of Spring Hill Hospital coming online. Would TennCare step in there to say, no, we want to have both? What is it? Why wouldn't you just negotiate the contracts? Why are we subjugating that negotiation away to the MCOs? Because aren't they just a pass-through of the state money that we provide? Why wouldn't we be negotiating those contracts to make sure that we have fairness across the whole state in the contracts?
Well, we certainly would want them to negotiate, but we don't have the capacity at the state level to do the negotiations. That's a huge part of what we're actually contracting with the MCO to do. Now, specifically for hospitals, as we sit here today, you have to remember that with this massive infusion we just made with the hospital investment program, our hospitals are getting commercial rates through Medicaid, which is something that I never thought we would see. So our hospitals are in a really good position, and there would be no incentive for a hospital to get out of the network, certainly, and there wouldn't be an incentive on the MCO side either, because yes, they're getting those MCO payments, but they're also getting the addition of the directed payment, which is going to bring them to essentially a commercial rate.
Okay.
But, excuse me, if the MCO cancels the contract with the hospital, the MCO stands to lose some members, and they get paid based on membership, right?
They do. Now, those members would still be assigned to them, but as you mentioned before, when that enrollment period, open enrollment period comes up, then yes, if those members are upset about losing a particular provider, then they very well could and possibly would, and maybe likely would, move to a different MCO. So
right.
that is something that the MCO would certainly have to consider. I think, Chairman Spicky, what you're getting at is, should TennCare step in and do the negotiations? And that's just contrary to the whole managed care philosophy or operations. And we're not a fee-for-service state. And we don't have the capacity to do that. If we were going to do that, then we'd have to grow our department. We'd have to grow government pretty significantly. And honestly, I don't think we'd be able to hire and have the same expertise as an MCO that's very sophisticated and does this every single day.
And now I'm going to shift gears real quick, Mr. Chairman. Can you tell us very briefly how you create the TennCare reserve?
Kindly, we have 10 minutes and 3 other members on the list. So
So we don't create the TennCare reserve, but the way the reserve works is we have a budgeted amount, and then anything that we're not spending that we have at the end of the year will go into that reserve. Now, I mentioned the large portion of it that's shared savings. Remember, as we have brought forward shared savings initiatives, we don't spend all of those allotments in one single year. And so they're spread across multiple fiscal years, actually going out all the way through FY31. And so that's why you see a lot of those shared savings dollars that are still in the reserve. But I think probably the most simple way to explain it is that we have the budget, and anything that's left over goes into the reserve.
And so my follow-up question to that is, we've had this dance before. I think in 3 years, we sent almost $2 billion back in reversion. $2 billion back in reversion.
Yeah.
Why wouldn't we hold that money into the reserve and build a reserve?
Yes, I understand. So that is something that is done at the FNA level in terms of how much of that would be transferred over to the general fund. And those are discussions that we have with FNA, but ultimately that's an FNA decision.
Well, thank you. We do have 3 members, and each of them 3 minutes because you were late. Representative Jones, you're recognized.
Hey, I just thank you so much for being here and really appreciate what you all did with the Hill Fund for our Northeast Tennessee counties that were impacted by the flood. It was really much needed and much appreciated, and has really made a difference in those communities. When you were explaining that, though, you said it was a TEMA grant, and my understanding is it's a loan and it has to be paid back over 10 years. If you want to change that to a grant, these counties would be very grateful again for that. So I'll just put a plug in if we want to change that. But is that correct? It is a loan?
That is correct. And thank you for correcting that. That is correct. It's a 0 interest loan.
Correct. Yeah. But like I say, we'll take that grant if y'all want to reconsider that.
Your request is duly noted.
Thank you.
Representative Scarborough, you're recognized.
Good morning. Thank you for being here. As a follow-up to Chairman Grill's question, you mentioned earlier the federal folks, they come up with the definition of refugee. And you said 8,051 claims were paid. Can you tell me what that total number is? If you don't have it on hand, you can get it to us later, but
yeah,
what that total number would be
in terms of a dollar amount?
Yes, sir.
Yes. And so that was a category that included all qualified non-citizens, which would include the refugees, but there may be others that are part of that So those seeking asylum or something like that. So for 2024, again, it was 8,051 members that had paid claims. $7 million state. About $20 million total, $7 million of that state.
And real quickly, following up Chairman Sapicki's question, is it possible, and you said it's F&A level, but to your knowledge, is it possible to retain those funds in a reserve in the future when we have those cost savings?
Well, so to the extent that we did generate any savings, those would, and our budget wasn't reduced, then those funds would end up in the reserve.
Thank you.
Since we didn't, because we didn't spend them.
Thank you, Chairman.
Thank you. Another quick number, Mr. Commissioner. What do we pay to the MCO per member cost to us?
We could probably give a rough estimate. It's going to vary a little bit because they don't have the exact same number, but do you have that, Zane?
It's highly variable because we stratify our population into different groups. Like, for instance, people with disabilities are in a different cohort and they're much more expensive than people without
A range
disabilities.
or an average?
On average, probably around $400 a month.
$400 a month. I remember it just used to be $1,400 a year. Chairman Hill, you recognize.
Thank you, Mr. Chairman, and I'll echo on the first part, and I'll be quick, but the Hill loan was huge. It was innovative, and as far as from being from the Upper East, we're very grateful that attitude and that perspective was undertaken by TennCare, because you guys didn't have to do it, and you found a way to be helpful to our end of the state and in a great time of need. So thank you. My question on the MCO side of the world, is there a mechanism that TennCare uses to, I guess it's a check and balance. You don't want to be involved in every contract. That's why you have an MCO. But is there a mechanism for transparency as far as their we would call it profitability. I mean, Blue Cross Blue Shield from the commercial side said we made X last year, right? In the relationship between TennCare and the MCOs, is there a clear picture of what their profitability is as far as a mechanism to see that from TennCare's perspective?
Yes, thank you for the question. So there is a couple of points there. So when we negotiate our contracts with the MCOs, we actually build in a 1% profit margin. And if you look where we were, ultimately where we ended up, prior to the pandemic, we were really close, like around 1.2, 1.4% typically. During the pandemic, which we saw across the country, that ticked up to about 3.5%. I will say that we clawed back a lot of money from our MCOs during that time because we did not want them to profit off of COVID. And so we brought back in, which also led to some of the higher reserves. And now post-pandemic, we're kind of back down to that 1.5%. We're back down to where we think that we should be. And I think most people would say, well, 1.5% profit margin is reasonable. It'd be very difficult for us to attract MCOs into our state if we didn't allow. But then on the back end, we also have the MLR, medical loss ratio, which puts a limit on how much an MCO can actually make, and then we have the ability to claw dollars back.
That was another question that I had. Do they and maybe, Mr. Chairman, we need to have, because we've had a lot of MCO questions, we maybe need to have the MCOs come before this committee if possible, but just so we can understand their processes better. But do they have the latitude? Does the MCO have the latitude to charge a management fee in effect to TennCare, and then on the back side of the negotiation, on the back of the providers, and ultimately on the back of the patients, to go ahead and profit again or make more money in that setting as well? Do they have the latitude based on the relationship with TennCare to go make money again, if that makes sense? Is that possible?
Well, I mean, when we have what we're looking at in terms of, when we look at that, what is that profit? It's very, it's very specific what would be included in that and what would be excluded. And then on the back end, you've got the MLR. And so I don't think that they would be able to do that. I mean, we want them to be efficient. It's actually to our benefit that they are at risk, because if ultimately we need them to be efficient, to be effective, to be conservative, because if they're not, then we're going to be coming to you asking for even more money than we're already asking for, which is very, very significant. But to your specific question, no, I don't think that they can do that.
Okay. Thank you, Chairman. Thank you.
Thank you, Chairman Hill. It's true, MCOs play a key role in the whole program. And at some point, if the committee's will to talk to them, if they're willing, we could do that. One final question. How do we answer schools that are calling us about TennCare not allowing payment for oral medications to children?
Yes, thank you for that question. So what I would say is, under our policy, we never intended to reimburse for just the distribution of oral medication. So in other words, just handing a child a pill for them to take. We don't do that in any other setting. And so when we talk about our school-based services, we need to be consistent. Unfortunately, what happened is there was some confusion about that particular policy. And in some cases, and this is a very limited number of school districts that were doing this, school districts that were working with one particular vendor. They were getting reimbursed for just the distribution of the oral medication. We caught this. It kind of goes back to, I'm not suggesting this was fraud at all, but we look at analytics. We're very proactive, trying to look at what are we seeing? Is there something wrong here? That was an instance where we saw that the cost had skyrocketed. And so when we drilled down into it, we discovered that what was happening in many of these cases, we were paying for just handing over a pill or distribution of the oral medication. And so we corrected it. We made it very clear within the policy that we don't pay for that. Now, we are going to give a grace period so that school districts can adjust. But that is the reason why you're hearing from some of the school districts.
Do you know offhand how much were you paying? The cost to TennCare?
The financial, well, we don't know the total. What we do know is we can drill it down to what we know the most common distribution was for ADHD medication. And if we look at that, it was about a $750,000 impact. But it's more than that because it would include other medication as well. But that we know at least it was $750,000.
If you can get the final number, how much you were paying for oral medication therapy and not paying for that, what would it save TennCare? That would be worthwhile for us to know. Thank you very much. Very thorough and very detailed, and thank you for answering our questions. Members, thank you for your interest and patience. We stand adjourned.